I am sure that for many years, most of us have discussed whether aspirin or warfarin therapy is better suited for patients with heart failure and low ejection fraction who are still in sinus rhythm. Certainly, as I've made teaching rounds on the cardiology surface, it has been a recurring question for which there has been, so far, no data-driven answer. Now, however, in the New England Journal of Medicine, researchers report on a trial that finally gives us an answer. They followed more than 2,000 patients with decreased ejection fractions in sinus rhythm for up to 6 years. Half were given warfarin and half aspirin. They then tested whether the time to first event of ischemic stroke, intracranial hemorrhage, or death from any cause differed in the two groups. As is frequently the case, the answer is not a black and white one, but here is the take-home message. The rates of the primary outcome, remember, that is time to stroke, bleed, or death, was identical in the two groups. In a time-varying analysis, there was a marginally better outcome in the warfarin group, but it barely made significance at 0.046. Warfarin was associated with a 50% reduction in ischemic stroke, but the actual number differences are small, at 0.7 events per 100 patient years versus 1.4 for aspirin. However, offsetting this was a doubling of the risk of major hemorrhage in the warfarin group. Rates of intracerebral hemorrhage were no different in the two groups. So here's the answer to our original question. Among patients in sinus rhythm with decreased EF and heart failure, there is no difference in this primary outcome. A reduction in risk of ischemic stroke for warfarin recipients is almost exactly offset by an increased risk of major bleeding. Now, with these data, we can make a sound clinical judgment between aspirin and warfarin that can be individualized for any of our patients. I'm Peter Block, and this is a CardioSource Heart Minute.